figure this out. There we go. I'm actually going to start out with a little bit of philosophy. And this is a new interest of mine that I've gained as I've gone back to school to get my PhD. And I'm reading about Aristotle, and this is a new word for you to remember, and maybe we'll add it to the Jeopardy game, phronesis. And phronesis is the intellectual capacity or virtue that belongs to particular endeavors rather than to science. Clinical judgment, which is what health professionals use, is the practical reasoning that enables healthcare providers fit their knowledge and experience to the circumstances of each patient. So then I ask, and this is my interest, how the particular knowledge that patients use and develop in their daily practices in order to live with their disease, how do we turn that knowledge into a science? It's not going to happen today, but certainly that's something that I'm going to be looking at in my future work. This talk is actually meant to give you credence for what you know and what you have taught us. I'm not going to be talking about many of these things in details, but telling you stories about how I learned from my patients and from my team that helped me take care of the MG patients. This was in an American document, Health Policy Brief, February 2013, and it talks about patient engagement. People actively involved in their health and healthcare tend to have better outcomes, and some evidence suggests lower costs. An important factor here in the US, and I thought this would be a good reason for us to encourage patient engagement, and you being here means you're engaged in learning about your health. So how do you learn about your disease? And Dr. Porter has already put up a slide regarding that, but I want you to think about when you're learning about your disease and living with your disease, how do you know what you know? Because patients know stuff, but how do they know that? And what does that mean to you? So knowing that, does that help you? Does that explain things, or does that make you more confused? And then try to answer the question, what are you going to do with the information of the things that you know as a patient? So you need to understand the diagnosis. You need to know what form of MG you've got. You need to know what symptoms are related to MG and what symptoms are not. But also you need to know all the different treatment options and then become engaged in making a decision that fits you. I also think it's important, and you do this well, is to understand the symptoms and how to manage them. And you manage them for yourself. There's lots of treatments we can give you. Prednisone works 80% of the time. That's the evidence. Do patients like prednisone? No. Patients hate prednisone. They may go on it the first time that you suggest it to them because they're naive and we tell them the side effects but sort of downplay it a little bit. But the second time you say to them, I really think we should put you back on prednisone, they go, no, I want something else. I will never go on that drug again. So we need to make a little bit of a balance, and that knowledge of what fits you in your life. Do you want to tolerate your symptoms for a long length of time, go on a low dose of prednisone, or do you want to go on a higher dose and get better? There's lots of ways to get information about this, but certainly how it fits for you is something that you need to decide. There's the list of the side effects. It's an old paper in 1984 by Dr. Pascuzzi regarding the side effects of prednisone. But prednisone works. Here's something that happened to one of my patients. So our patients like to go to Florida for Christmas or for the whole winter. And can you guess what happened here? Because you guys are a very smart group. He's a 75-year-old snowbird. He goes every year. He's got ocular myasthenia gravis. He's on the standard medications, prednisone, azathioprine, and some mestinon. His condition's stable. He hasn't had an exacerbation for a long time. Comes back to Canada early and calls me, and this is what he is hospitalized for. He's got elevated liver function tests. Sorry, I had to use that. 6 times normal. He's icteric, which means he's yellow. He's jaundiced. He has a tremor, and he has severe fatigue, more fatigue than you have with MG. What drug causes these symptoms? Imuran. So this is a fellow who was on Imuran, and when our patients go to the States or even in Canada, we ask them to have blood tests of their liver enzymes every month or every 2 months, depending on stability and drug changes. He didn't do that was he in the States because he'd have to pay for it. I think it costs about $30 to get the test done if you're from Canada. But it's not the problem that he didn't have the test done. That was part of the problem. The other problem was he decided to take St. John's wort, which is an herbal medication for depression. And we suspect, will never be proven, that the combination of the two caused this. He actually recovered and did not require liver transplant. However, I use this story with every Canadian patient who wants to go to the States and say, if you can afford to go to Florida, you can afford to pay the $30 to get the blood test and have them send it to me, and it works. These are the other things that you will need to learn about, and most of you will know when it's on the MGFA website, drugs you cannot have, and drugs that are supposed to be used with caution. And it's an important thing. Either have it on a stick that you carry with you when you go to the pharmacy. Make sure your pharmacy has a copy. Carry it with you to every doctor you go to. And despite the knowledge that's out there and despite the checking, it still occurs, unfortunately. And so I bring this up just because I think it's really, really important. Your other part of the healthcare team, and the healthcare team person that I use a lot, is the pharmacist. There's a lot of people who get MG and are already on 5 medications, and then we add a whole bunch more. And it's very helpful to use your pharmacist to see whether or not there's any interactions, and I will often do that. But I insist, and I would recommend, that you also include sort of those things you use for the odd headache, the odd ache and pain, the vitamins, the supplements, the drinks you take, the injectables, the creams that you use, Voltaren cream, eye drops, alcohol, and then don't forget to add immunoglobulin to your list, immunizations. So the pharmacist is really important, and I actually use the pharmacist a lot in terms of sorting out the best options given the rest of their medications. This is the fatigue and MG slide, and this slide actually is compliments of Ann Williams, who used it to teach nursing students, and she's not here today, unfortunately, but is very involved in the Nurses Advisory Board. And I'm sure that you can relate to that. And you all know what makes your fatigue worse. But when you come into the clinic and you talk to the physicians or the nurses and you say, my number one problem is fatigue, I will ask you more questions. Say, yes, you've got MG, but what kind of fatigue is it? Is it muscle fatigue when you use it, or is it whole body fatigue? Are you tired, or are you sleepy? Do you take naps during the day? And sleep apnea is very prevalent in patients with MG, and often is the thing that I will look for in an individual who has no other signs of active MG, so no droopy eyelid, no problem swallowing, and yet comes to me and says, this MG is awful, I am fatigued. The incidence of obstructive sleep apnea in a study that was done, and there's been more studies done since, is 36 compared to the expected prevalence of 15 to 20%, so it is higher. We're going to have some other talks about myasthenic crisis, so I'm not going to talk about it in detail, except to say, again, this is where the team members that I work with are very important. The speech-language pathologist who knows every piece of anatomy that you use in order to chew and to get that food from your mouth into your stomach. They talk about things like, is this an oral problem with swallowing? You can't chew, you can't seal your lips, you can't gather the food with your tongue to make it into a bolus. There's different kinds of swallowing. Or is it just because you have a slow trigger, you just can't get it down there? Or the airway doesn't close? Or you get residue pockets? Or do you have material going into your airway? And so what can happen? We probably all know this. There's aspiration, you can have choking, poor nutrition, weight loss. People automatically will just change how they eat before they even possibly call the clinics or their physicians. As soon as they know it's not chewing right, they'll go, okay, well, I just won't eat chicken anymore. I'll just cut it up really fine. I go to soups. The last patient that we ended up admitting to hospital had been eating 1 boost a day. It took her all day to get a boost down before she called to say, I think I have a problem. People just get used to it. These are the assessments, and you talked about them, about using swallowing tests to diagnose MG. There is one study done, I think, quite a while ago, 2005, which actually did a swallowing study to look at the characteristics of MG swallowing problems versus other swallowing problems. So it is helpful. The new assessment, and I don't know if you're using it here, and you probably are, but we're using the fiber optic endoscopic evaluation of swallowing at the bedside. It's much nicer. It's easier done. It's done by the speech language pathologist, so you don't need to have an x-ray done, and you do not need to go to the x-ray department. The treatments of MG we've talked about, and then there's the modifications that patients do. The next member of my MG healthcare team that I am very close to, especially when people are in crisis, is the respirologist, the intensive care physician, the physiotherapist, and the respiratory therapist. They are invaluable when individuals with myasthenia get into trouble. They can decide whether or not to use the non-invasive BiPAP rather than intubating you when you're in a crisis. They can also help you with cough assist devices. So if you have a pneumonia, are we able to use breast stacking or other physiotherapy type of devices like a cough assist to help you with the pneumonia? I had a patient whose vital capacity was down low enough that she had to go to ICU, and she refused. She literally refused. And I sat at her bedside and I said, you have to go to ICU. This is much too low. And she goes, I will not. And I said to her, you may die. And she goes, I will not. The physiotherapist came in and did cough assist and breast stacking with her, which is quite fatiguing, and I was concerned. But she taught me that there was a way to do that with MG patients, and she avoided the ICU visit. So it was a good learning point for me from a physiotherapist. And of course, we like to prevent anything that's happening there as well. This is the breathing stuff that the intensivists and the respiratory therapists know all about. They know all that anatomy, and I depend on them on determining whether or not the breathing problem is related to the diaphragm, which is involved in myasthenia gravis, versus the lungs itself. And this is the last thing which all of you know and do, and it's the sort of mother nature of taking care of everybody, is promoting your healthy living with MG. And don't forget about preventing osteoporosis with the prednisone, because that is a horrible, horrible thing. Avoiding viral illnesses, getting your immunizations, and limiting your alcohol. It's important to continue to live. And I ask all my patients, I want to help you live with this. I don't want you to just put up with it. And so how can I help you do that? And that's different for everybody. So some people want their leisure time. Some people want to go back to work. Some people want to be effective at home. Some people just want to be a good friend and want to do things with their friends or with their family and spouses. But most of all, I want to encourage you to be hopeful. And over the last couple of years, I was involved in a study that I did in London with my 100 MG patients. And in fact, over the course of 10 years, patients did have a good level of hope. And the things that helped them was their support and the fact that they knew that there was someone they could call. So good neurologists and good neurocare actually can give you hope. Thank you.